Good morning, Paul. Lovely to have you with me again today for just a quick chat about some important things that are coming up in the world of diabetes. There's been quite a bit of a buzz about a recent Lancet article about the type 2 diabetes path to remission program. What's so special about it?
Well, hi, Cheryl. Yeah, thanks for inviting me to this. I think this is one of those pieces of research that managed to get national news. I woke up a couple of days ago to Radio 4, as I always do, and there was someone talking about this amazing soups and shakes diet. And as you say, the Lancet paper that was published. And I think for me, the really unique bit about this is real world effectiveness of the soups and shakes diet. So up until now, most of the non-anecdotal work that's been done on soups and shakes has been in a formal research setting. So you sign up to a research program, you get followed up in a more thorough way than you would do in a normal clinical situation. Whereas this is an observational study. It was actually undertaken or published by Jonathan Valabji, who was the previous director of Diabetes UK. And he and his team looked at 2 years worth of real world data. So just patients that have been referred into a program like I might do. And it works. I mean, in summary, it works. It doesn't work for everyone. It doesn't work 100% of the time. But for me, the takeaway message is that if we have patients who are recently diagnosed with type 2 diabetes and they're between 18 and 65 and they want to go onto this program, it works. Now, I'm very happy to go into more detail. Perhaps that would be interesting.
Yeah, I mean, it would be good to know, excuse me, in summary, why does it work?
Well, I think most of us are agreed that type 2 diabetes, the incidence is obviously going up and up in the present world, and a significant part of that is around obesity and diet. Not 100%. Again, there's definitely some genetic components, but a lot of it's around obesity and diet. And so this program decreases your calorific intake for 3 months, 12 weeks, and during which time you lose weight. Now, say this paper observed over 7,500 patients that have been referred. So this is now firmly established, I think, in the UK at least, as best practice for patients with type 2 diabetes recently diagnosed. So just going through the figures, about 7,500 patients took part. Now, Jonathan Vlabji, only looked at completed patients. So the program was observed for 2 years, but it's a 1-year program. So obviously, if you started a year and a month into it, you couldn't have finished it by the end of this observational study. So the figures are a bit skewed because of that. But essentially, of those 7,500, only 945 completed the program and had blood tests. But you can imagine there will be a lot who completed it without blood tests and a lot who hadn't actually finished the program within that 2-year scope because they started within, say, 6 months of the end of the program. These figures are going to be as pessimistic as a trial can be, so the figures are likely in the real world to be better than this trial suggests. But of those 945, 32 over 300 patients went into formal remission. So now you can take two views on this. I think you can say, well, 7,500 patients and 320 went into remission. That's not very many. Or you could say, well, without this trial or without this program, no one is likely to have gone into mission, or at least very few are likely to go into mission. And for those 320, absolutely life-saving and game-changing and life-changing and so many positives. So
I was going to say, Paul, why is remission, getting people into remission, so important for those with diabetes?
This, I think, is the really interesting part of the whole program. Up until relatively recently, probably 10 years, maybe a little bit longer, depending on which paper you read, type 2 diabetes was thought to be an illness that didn't relent. It continued. It made all of your risks of cardiovascular disease, strokes, heart attacks, blindness, kidney failure, all of those things we know increase the risk of all of those problems. Whereas if you can go into remission, your risk of all of those illnesses decrease substantially. And in fact, we're not sure yet because it's a relatively new program, but we think that the risks substantially decrease, not back to baseline. So we would say this is remission. It's not cure. You will always be on the diabetes QOF program, so you'll always need to be monitored yearly as a standard type 2 diabetic, as a standard a patient living with type 2 diabetes would be. So you're in remission, you're not in cure, but your risks substantially decrease. Now, just again to put some figures, 7,500 referred, 1,700 patients started the program, 945 patients completed the program, 320 patients, about a third, went into remission. Now that's lower than might be suggested with the direct trial, but as I've explained, I think these figures are likely to be higher if you expand the window of observation. A couple of other things that I think it's worth saying. The patients are much more likely to obtain remission if they have a short duration of diagnosis. So within a year of diagnosis, if they're referred, that increases their chances of going into remission. If they have a relatively low HbA1c at the start of the program, and also if they have significant weight loss. I think, again, talking about weight loss, on average, people lost 10.3 kilos in the program, which is a huge amount. People who went into remission lost over 15 kilos on average. So again, I think the more you lose, obviously, the better it's likely to be. Now, and again, we also talk about remission as the endpoint of this. Many patients won't have gone into formal remission, but their diabetes will still be substantially improved in terms of reduction of medication or in terms of reduction of HbA1c, and therefore they put off the time at which they need to have an escalation of their drugs. So although remission is the endpoint, and a third of patients went into remission who finished the program, it's still those 2/3 who didn't go into remission still have substantial benefit.
So what we're saying really then, this is an intervention, and it's a path to a better lifestyle which helps manage diabetes in the long term, whatever the outcome from the program.
Absolutely. I think the issue for me will always be those patients who finish the program are likely to have substantial benefit. Those patients who partly finish the program will have benefit, but not as much. Those patients who don't take part in the program at all need to be offered other therapy, other interventions, because it's not for everyone. 12 weeks of a total dietary replacement, I would struggle with. I've taken some of these replacements. They're palatable, they're okay, but they're not delicious. But this is the most effective intervention we have in terms of lifestyle at present. Just one other point I'd like to make is that of all the patients who have been referred, 35%, about a third of them, were on no medication at all. And another 50% were just on one medication. So 85% were either on no or one medication for their diabetes. So in other words, 15% were on two or more. So again, this talks to the earlier we get them referred, the more likely they are to go into remission, the more likely they are to have substantial benefit. So we as doctors and nursing colleagues always get very worried about people on 3 or 4 medications for their diabetes. Yes, but they probably aren't going to do as well as the patients who are on 0 or 1 because they're further down the path of their diabetes progress. So again, really interesting. The message is quite clear. Refer them early, refer them before all the end organ damage, and then support them as best we can to actually go onto the program, because it is, in some patients, life-changing. If they choose not to go onto the program, obviously there's all sorts of, a little bit of weight loss will help, more weight loss will help more. We know that from this trial. And but I'm not underestimating that this is an easy thing to do, but in the well-motivated patient, I think it's absolutely life-changing. And we now have real world evidence, not in a research setting, that it can be delivered at scale across the whole of the UK. And I think that is amazing.
It is indeed. It's great that we have this intervention available to us. So let's use it for the right patients. So thank you very much, Paul. Great as ever to talk to you.
Great stuff. Thanks, Cheryl. Good to see you.